Okay, hello and welcome to another Harvard Northeastern Misinformation Speaker Series event. My name is Bryony Thompson, and I'm co-hosting this year with Matt Baum and David Lazar. A quick reminder of our other talks this semester. On April 21st, we have Naomi Oreskes at 3 p.m. speaking on The Big Myth, How American Business Taught Us to Loathe Government and Love the Free Market. And then on May 5th, we have Renee DeResta at 11:30 speaking on Invisible Rulers, the people who turn lies into reality. But for now, I'm extremely excited to introduce today's speaker, Skyler Johnson, who's a physician and an assistant professor in the Department of Radiation Oncology at the University of Utah Huntsman Cancer Institute. He's talking today on combating cancer misinformation, impacts, challenges, and opportunities. Just a reminder for the online audience to pop is that right? They're popping their questions in the Q&A. But yes, it's not every day that you read a paper. In 2018, I read a paper of Skyler's about use of alternative medicine for cancer and its impact on survival. And I thought, wow, this is so unbelievably important that it changed my research direction. So I sent Skyler a cold email, and we've been working together ever since. And I often use Skyler as an example, as people who are in the trenches. Like us researchers, we're behind a laptop and we're often just like thinking about things and considering them. And it's incredibly different to, looking people in the eye and actually convincing them to adhere to evidence-based medicine. So thanks very much, Skyler.
Thank you, Bryony. That was a very, very kind introduction. I am so grateful for the opportunity to be able to talk about this important topic. I appreciate the invitation and the opportunity to develop relationships with people who are as passionate as I am about this problem that we see day in and day out. So I always like to start with this because, as you may see later in my slides, it does become important. And the reason I bring it up is because I don't have any industry funding that's directly related to any of this research. I have some funding that was for an investigator-initiated prostate cancer trial and some honorarium for travel and speaking. So I like to start with a case. And this case has been changed. I've changed important details just to protect the identity of the individual involved. But let's call this individual SD. She's a 38-year-old female who noted that she had a lump on the left side of her chest in December of 2017. There was a physical exam done and a mammogram and an ultrasound that confirmed that she had not only a mass in her breast, but there was also some possible lymph nodes that could have had cancer in them as well. There was a biopsy recommended. However, she declined this test because she had heard from a trusted family member who read online that a biopsy would spread the cancer. Following multiple discussions with her doctor, she opted to treat the breast mass naturally with a raw food diet. After 18 months, she returned to the doctor's office and the breast mass had enlarged. There was now some skin redness and some nipple discharge that was bloody. There's some imaging that she did agree to do. It was an ultrasound, and it confirmed that this mass was getting bigger, as well as the lymph nodes. At that point, because things were growing, she agreed to a biopsy, and it showed that she had an aggressive form of breast cancer, an invasive ductal carcinoma that was hormone negative in the left breast and in her lymph nodes of the armpit. She declined treatment at that point, despite the recommendation of our multidisciplinary physician team, in favor of what was IV vitamin C. 3 months later, she returned to the doctor's office, and now the entire skin of the breast was red. She had a bunch of nodules that were now kind of breaking through the skin, and she was told by her provider at that time that this was her cancer being like naturally evicted from her body, and that this was a good thing. Unfortunately, anybody who knows much about breast cancer staging, this is a very advanced form of breast cancer. And she continued to decline the treatment recommendations from the physician team. The family paid for her to travel to Mexico at that point for what was hyperbaric oxygen and natural chemotherapy. And 6 weeks after that trip, she came back to the United States and presented to the emergency department with severe back and hip pain. During the interim period while she was in Mexico, the mass broke through the skin. It bled so uncontrollably, she had to have an emergency surgery and had a palliative mastectomy while in Mexico. She continued to believe that her body was naturally expelling the tumor from her body at that point. Unfortunately, that back and hip pain was found to be widely metastatic breast cancer to her bones. At the time of her initial diagnosis, depending on obviously cancer type and stage, but for early localized breast cancers, cure rates can be around 85% on average overall survival over a 5-year period. At this point, this is an incurable breast cancer. Over the subsequent 6 months, she did eventually accept treatment at the recommendation of her physicians, but it was palliative treatment at that point, just for symptom management and control. She got some chemotherapy. She also had radiation for pain, but unfortunately, despite her best efforts, she developed brain metastases to her brain and died. So the point of bringing up this case is that there are real negative consequences to cancer misinformation. The acceptance of and the adoptance of these types of treatments are harmful for our patients. And when we talk about cancer misinformation, we talk about what is false, misleading, or inaccurate information about cancer. And it's important to look at this because it can lead to harmful consequences that can delay medical care, like in this example. It increases anxiety or confusion for patients and their families. That results in the refusal of evidence-based treatments. It interferes with evidence-based treatments. Sometimes there's these herbal remedies that can impact how chemotherapy is metabolized in a person's body, either making it ineffective or sometimes more toxic. And there's also financial exploitation involved. In combination, these things can result in poor health outcomes. And you might think, oh, Dr. Johnson, he selected this story because it sensationalizes this issue of cancer treatment misinformation. But I can promise you, unfortunately, these stories are very common in oncology care. And these are the types of situations that really keep us up at night, because no matter how advanced and how effective our treatments can be, they will not help people if they choose not to use them. Generally speaking, broadly, these misinformation epidemics create a perfect storm that impact the health of our populations. This slide is credit Sylvia Chu. How this health content is ubiquitous. There can be misinformation silos or echo chambers that impact individuals, that result in more engagement and get emotional reactions from people. The credible evidence that we have, especially in cancer care, can be very complex and nuanced. It's often changing, which is challenging for individuals, and there's uncertainty involved. I think this last point is interesting. Obviously, there's politics and ideologies that impact these misinformation epidemics, especially in the current political climate that we are in today. In fact, this slide came from Sylvia Chu at an event we were supposed to be speaking with together, but unfortunately fortunately she works at the NCI, but unfortunately at that time she was barred from speaking publicly. And so I thought that was very ironic. Broadly speaking, health misinformation is a major issue, but I think it's worth mentioning that cancer is a model topic when studying misinformation, and not even just health misinformation. And the reason that I say this is because studying cancer misinformation is an opportunity to look at objective outcomes and the incidences that result in those outcomes. We know that cancer misinformation, there's high prevalence, but there's also high prevalence of cancer diagnoses as well. So there's opportunities here to study individuals who are at risk of potential harm. We know that there's clear financial incentives behind the disinformation that people may be spreading. And we know that cancer patients are uniquely vulnerable position, oftentimes faced with a lot of anxiety and uncertainty, and in a position where they may make decisions that are not in their best health interest. And we know that trust in science and medical professionals is central to the models surrounding communicating the evidence behind cancer treatments. And as I had mentioned, it's important to look at the objective outcomes, right? Yeah.
Yeah, just a quick question. Is it possible to do the work you're describing here if, as I think it has, the NIH stops collecting data?
It is, but it requires novel approaches. And I'll actually talk about some of the novel approaches that we've used to try to get at some of this data. The issue is that it's almost impossible, not quite impossible, almost impossible to get direct causation without prospective work, which is often NIH funded. And I mean, I think the benefit of being in the United States with government funding of research is that it does allow for long-term outcomes work, which is what you need in this space.
So I notice you have financial incentives there up on line 2, but you're at the Kennedy School of Government and you don't mention political influences. And it seems like right now we're in a world where Trump and Kennedy are as responsible for misinformation as anything we would see from charlatans who are out to make a buck from their misinformation. Can you comment on the political environment and how that feeds into your talk?
Yeah, it's incredibly challenging to try to address misinformation when influential individuals in positions of power are purveyors of that misinformation. It creates an almost insurmountable challenge. I'm not sure what the answers are or how we overcome that. I will say I'm heartened by the community of scientists that I can continue to engage with, many of whom are in this room who I believe with our collective efforts are going to be more powerful than those individuals. I don't think that answers your question, but I don't think I've got a great one for it. The importance here is that in cancer treatment, we can see what happens to people when they are impacted by misinformation. We can see whether they adhere to treatments that are recommended by physicians. We can see what happens with their cancer control rates and their survival. So there's really concrete outcomes that you can look at that may be impacted by misinformation. There's major challenges though, and it's a tough area to be in because the definitions of cancer misinformation can be very broad and they can be very context dependent. So for example, we often talk about cancer along this continuum from the causes of cancer to trying to prevent it, to how you detect it, to how you diagnose it and treat it, and then what happens after people are treated. And cancer misinformation can impact people, just like in that case that I described, at any point along this cancer continuum. And it's really hard because you can't just go to a patient and say, have you been exposed to cancer treatment misinformation or cancer misinformation? They're not going to really know even what that means. So it requires kind of this operationalization of a definition that they understand, but also is meaningful in a research context. And it's really difficult to quantify and study that exposure because oftentimes people are being exposed from multiple sources, right? It can be word of mouth, it can be social media, it can be a friend of a family member. And then how do you quantify that? Is that 3 exposures or is one more important than the other? So it just creates this really difficult environment and it's tough to describe those sources. These individuals who are oftentimes prone to misinformation in some cases have some skepticism surrounding the traditional healthcare system in which they may not want to be followed or seen, and that makes it difficult. And I'm not saying anything that this room doesn't understand well. Behavior is very complex. Decision-making is very complex. And in the cancer context, studying or following treatment adherence can be very complex as well, because every cancer stage, every cancer type is different, right? We've got thousands of different types of cancers. We've got stages within those cancers. Those treatment recommendations vary. And it's oftentimes changing, like was said on the prior slide. So as the evolving information, or as that cancer treatment science changes and evolves as we gain more knowledge, that can be disconcerting to some people because it's new and different. We've, at least to this point, tried to do most of our work in the area of treatment, cancer treatment misinformation, because we feel like this is where there's an opportunity to have the greatest impact on individuals. And the challenge has been here in this space, despite lots of work here, this kind of operationalization of the term cancer treatment misinformation. So the way that we've defined it in most of our work are recommendations to pursue unproven or disproven cancer treatments, to forego recommended conventional cancer treatments like surgery, radiation, chemotherapy, those things that have been proven to work in many cases, or 3, adopt myths or misconceptions that could directly or indirectly affect cancer treatment. Some people might say, okay, well, what does that mean? Or how do these results actually impact patients? And when you talk about, well, without NIH funding, how do we study this type of thing? Well, there are national databases that we have access to. This is a national cancer database that collects 70% of all new cancer diagnoses across the United States. They're de-identified. They collect information around the cancer type, staging, patient demographic information, and survival, in addition to their treatment information. So one of the things that we did is we looked at the 4 most common cancers: breast, prostate, lung, and colorectal cancer. We looked at individuals who didn't have metastatic disease, because we wanted to look at individuals who were potentially curable and were treated with curative intent. And we identified a group of individuals who used unproven cancer treatments, which we defined in the study as alternative cancer treatments. These were things that were administered by non-medical personnel who did not receive any conventional cancer therapies. And what we first wanted to look at is who were making these types of decisions. So it was more often to be individuals with breast and lung cancer as compared to prostate cancer, individuals with higher education by zip code, as opposed to those with a lower education by zip code. Those individuals in the Intermountain West or Pacific regions showed a higher utilization of these therapies as compared to the Northeast.
That just made me, oh, it's on. That just made me wonder, is there a gender dimension to this net of type of cancer?
Yeah, so there is. In the later work that we did, we not only looked at this kind of unproven cancer treatment use, but we looked at people who used unproven cancer treatments combined with conventional cancer treatments. And it appears as though there's a higher use of these types of therapies amongst the female population, but only about, I believe it's between like 1.5 and 2-fold. But again, in part, and we can talk about this later, I think that there are reasons why individuals might have some skepticism towards the kind of traditional medical system. And I think one of the things we've done a poor job of as physicians is, and as kind of a medical complex, if you'd like to say, is that we've not done a good job of acknowledging the lived experience of individuals who might be minoritized populations and treated poorly by the medical system historically.
So you say 1.5 to 2-fold, so 150 to 200%.
As compared to men.
So a huge difference.
Yeah, and part of that, yeah, is driven by the number of the, yeah, and that's partly driven by the breast cancer population in this study. Other features that were important was more advanced stage, right? Stages 2 and 3 were more likely to make this decision as opposed to stage 1. When you look at the overall survival by a specific cancer type, you can see that these individuals on the dotted lines are those who used conventional cancer treatments as recommended by those physicians. Those on the solid line are those who used unproven cancer treatments or alternative cancer treatments. The lower you are on this graph, the higher risk of death you have over the study period. So this is for our breast cancer population. For our prostate cancer population, this was a non-statistically significant difference, although we can talk about why that is. The lung cancer population, and then our colorectal cancer population. And when you look at these numbers, right, like I'm a physician, but I'm also a researcher. So I'm looking at these numbers, I'm looking at the statistics, and then it dawns on me that like every one of these drops that you see on this solid line represents individuals who made a decision that ultimately resulted in the early end of their life where they could have been on the dotted line. And that is a sobering realization when we're looking at numbers, but recognizing these are actual individuals who are making this decision. When we controlled for cancer type, for race, for insurance type, for facility type, for clinical stage, for comorbidities, you can see that individuals with breast cancer were much more likely they had nearly a 5.7-fold increased risk of death by using these treatments. Lung cancer was 2.2, colorectal cancer 4.6, and for prostate cancer 1.7, although not statistically significant. So there's a lot of ways that we could discuss this data. Why was the difference seen not great? Or some people say, well, it's actually not so bad. They could have been much worse. These are questions that journalists asked me after this research was published. The reality is that prostate cancer, for example, it has a long natural history. The median follow-up in this study was only 5 years. The natural history of prostate cancer in some settings can be 10 years or longer. And many of the patients in this study had lower stages of cancer than more advanced stages of cancer. So again, the natural history of this is much longer. And it's always possible that individuals potentially tried alternative medicines first, or they received conventional treatments later. I'll talk about Steve Jobs in a second. Interestingly, the unproven cancer treatment group, or the alternative medicine group, had a number of features that we typically presume is more likely associated with longer survival, like younger age, healthier, more educated and affluent than the other groups. So in conclusion, it may not be surprising to many of you, using unproven cancer treatments and foregoing conventional cancer treatments varies widely, but for the primary treatment of curable cancer has a greater risk of death. And no matter how advanced, as I said previously, effective cancer treatments are, people won't benefit if they decide not to take them. So we published this in 2018. And I bring up these slides not as like a pat on the back to be like, oh, look how great this research was. Because as you can see, it was pretty simple. Again, it was kind of a novel approach using some data that we were able to have access to. It was observational, right? It's not too complex. And I wasn't surprised by it. We saw it in clinic all of the time. We knew what kind of happened to these individuals. So we thought it was kind of going to be this like flash in the pan thing that nobody was really interested in. But as you can see from kind of the Twitter demographics, that people were interested in this almost internationally. And there was a lot of news coverage that started to come out in a lot of different languages, a lot of different countries, obviously. And it became, I think at current count, somewhere around like 400 news articles that came from that individual research by itself. And one of the things that we did is we followed up this study by looking at individuals who used unproven cancer treatments combined with their conventional cancer treatments. And in this study, this is kind of this group of individuals that fall within this categorization here, where they're using it together. So it's like somebody who would use IV vitamin C, but they'll say, yeah, I'll also do the chemotherapy that's being recommended as well. And again, this is challenging. This data is imperfect. It is not as specific as we would have liked because it didn't tell us exactly what people were using. And it could have been any number of things using any number of routes of administration. But when we looked at these individuals, and the reason we wanted to is because although we think that meditation, yoga, exercise, these types of things have traditionally been called complementary medicine, we think those are great. They're good. They can manage symptoms, they make people feel better. But the issue is that 2/3 of people who use these therapies believe that they're going to prolong their life. And they often include things that are not like mind-body therapies like yoga or meditation. They include things like, rectal enemas with coffee, or they can be ivermectin or things that you often hear about. And 1/3 of individuals expect these types of therapies to cure their cancer, and it causes some concerns. And in part, we feel like it may delay conventional cancer treatments, or they may refuse other conventional cancer treatments, or it could directly or indirectly interfere with their treatment. So when we did this study, we showed that complementary medicine was associated with worse 5-year survival compared to no complementary medicine, which again is quite interesting, especially when you consider that many of these individuals who are using these therapies have the means and resources to access complementary medicines, because they're not traditionally covered via kind of like our insurance program. So they're oftentimes paying out of pocket for them. They typically come from higher socioeconomic groups than otherwise.
What would happen if you limited the complementary medicine to simply the ones that you, a few minutes ago, sounded like you approved of? Would you still?
There's no difference in survival.
There's no difference.
Yeah, the interesting thing is the data, that the lines are almost overlapping perfectly. The issue is that because those individuals are typically younger, healthier, more affluent, have better health insurance, come from higher socioeconomic statuses, you would expect them to have higher survival. So the fact that it's similar gives me some pause. But again, the mind-body therapies, I think, are fine. That what I've tried to do in our research is really separate those things that may result in subjective improvement versus those things that have the potential for harm. When we controlled for those important factors known to impact survival, it remained an independent and significant variable for the impact of death on these patients. And again, broad interest nationally and internationally, same thing kind of happened. And again, it's not a pat on the back, but it's just to describe that there's so much broad interest and national interest and international interest in this type of work that it was really like caught us off guard. Now, not all of the responses were favorable, right? This is an example of an email that I got. I usually like to put more in my slides, but if anybody has Outlook here and has tried to search it like I did, it's always tough. It's always tough to find what you wanted to see. So I'll tell you about one I couldn't find that was kind of funny. But this is an interesting study that was just basically saying that they've met many people who've died from chemotherapy, but not from the fruit of the soursop tree, and that I need to look into that. And my favorite sentence is the second to last sentence that says, "Your research makes no sense. I'm sorry." And it's like, oh. This was an email that we got from the version of the Swiss FDA that wanted to help us, or they asked us to comment on a legal case where a surgeon was placing discs in patients and scanning those discs, saying that they were associated with a barcode that could cure cancer, and they were pressing charges against that provider. So that was kind of interesting. And then there was more of these emails where people basically said, "How can you live with yourself? Doctors are criminals." And are only care about money. And it says, "I really hope you understand this and change your life. May God help you." The other email that I couldn't find was somebody who was like, "How do you sleep at night?" Which was funny because I had at the time like 3 kids under the ages of 6, and I was like, "I've not slept in years." It's just how it is. And then interestingly, you see these studies or these blog posts that show up on Facebook that say that we're attacking alternative medicine, and it just proves that we're biased by industry. At this time, I had no industry relationships, no funding whatsoever. And so this came as a surprise to me, because I was like, if I'm supposed to be getting money, then somebody should tell me, right? Like, I should know about this. But it basically says that, of course, that doesn't mean the study authors are corrupt, but it's pretty hard to stay clean when you're swimming in a swamp. And we have to wonder, like, how impactful is the work that we're doing? Does it actually reach the people that we want it to reach? Does it move the needle in some of these spaces? And this blog post about our research was shared nearly 3,000 times on Facebook. Does anybody want to guess how many times our studies were shared on Facebook? 150 times. So we're facing obviously an uphill battle in some ways as it comes to communicating about cancer and misinformation. In 2018, following these two studies, ASCO did an annual survey where they asked adult individuals whether they believed that alternative medicines could cure their cancer without the use of standard cancer treatments. Yeah.
Did you create,
Did you create user-friendly posts comparable to, because, or is it just the paper?
No, just the paper. We did try to do some infographics that we put out on Twitter that actually did have some favorable responses, but again, it's a mixed bag and anytime you do these types of things. But messaging is obviously something that physicians aren't very well trained on. You may not be surprised to know that, but it was something that I feel like I'm getting better at now, but at the time did not. So this was alarming, right? ASCO did this study and they found that nearly 4 in 10 individuals, these are US adults, feel like they could cure cancer without standard cancer treatments. This is after our studies had come out. And to highlight kind of the importance of this issue, the NCI released a research priority called Misinformation in the Age of Social Media. And there's more to this, but these are the three main ones that we were looking at. Mainly, one, what is the prevalence of cancer-related misinformation on social media platforms? When we did a bunch of these interviews after these studies were published, many of the journalists were like, well, where are people encountering misinformation? I think a lot of individuals felt like it was coming predominantly from social media for good reason, given kind of the time frame of these studies. And so we wanted to look into that, specifically, and especially if we want to tackle cancer misinformation online in this ever-changing environment. So we published a study in JNCI. It was a brief report where ultimately we did some web scraping of 200 of the most popular cancer treatment-related articles online, basically via Facebook, Pinterest, Twitter, and Reddit. And we enlisted the help of NCCN experts. These are individuals who create the US guidelines for cancer treatment. So they're broadly considered as the experts for their cancer types in the United States. And we looked at the 4 most common cancers, again, breast, colorectal, lung, and prostate cancer. And we looked at the association of total and Facebook engagements between those who were considered misinformation and those that were considered harmful information. And I'll go through some of this relatively quickly, but suffice it to say, about 1 in 3 of all articles contained misinformation. And if you looked at just those, nearly 77% of those contained the potential for harm. What was most alarming is that the online engagement for these articles that contain misinformation and harmful information was increased when compared to factual and safe articles. So these articles that were harmful and false got way more engagement. That means likes, shares, comments, things of that nature, depending on the social media site that they were on. And when we looked at Facebook specifically, that continued to hold true. Now, misinformation was most commonly described by the raters in this situation as being misleading, or the strength of the evidence being mischaracterized, or recommending unproven therapies. Many of the harmful information was stuff that was harmful inaction, which they thought could lead to delays in seeking medical attention or cure, economic harms, harmful actions, and harmful interactions. And you can look at the engagement data for those articles that have misinformation compared to factual information, and those that are harmful compared to those that were safe. So the summary is here. 1/3 of popular cancer articles on social media contain misinformation, and the majority of these contain the potential for harm. And I like to put this quote up. It says, "A lie can travel halfway around the world before the truth puts its shoes on." And that's from Mark Twain. And I like to put it up there because it's probably not from Mark Twain. That's misinformation. But the quote, I think, stands despite not knowing who to attribute that quote to. And we've got our work cut out for us. So cancer misinformation is prevalent online, but do adults encounter it? Do they say they encounter it? Does it impact them at all? And that's what these next few slides show, is that when you ask adults, this is a collaboration I did with a collaborator at the University of Florida, Carmen Byland, slide to her credit, and there's some other slides in here that she's helped create as well. But 93% of respondents reported being exposed to some aspect of cancer treatment misinformation. And 78% had heard at least one of the National Cancer Institute's myths and misconceptions. These are a list of questions that they list on their website. And many cancer patients had heard that they could cure their cancer with herbs and supplements, diets, vitamins, minerals, mind-body therapies, and some other therapies as well. And the question becomes, do people believe this information? The answer is yes, people believe this. Smart people believe this. Smart people with access to, top of the world healthcare, with unlimited resources, believe this. This is somebody you may recognize. This is Steve Jobs. He had a neuroendocrine pancreatic cancer. It's a less aggressive form of pancreatic cancer that is potentially curable. Despite his diagnosis, he decided that he wanted to buck the trend of using what he referred to as Western medicine, and he wanted to use Eastern medicines to basically cure his cancer. Unfortunately, his cancer spread to his liver. Despite liver transplant later on down the line, he eventually succumbed to his disease. Now, we know from his biography that this is a decision that he later regretted. And we have to ask ourselves why. Like, why is it that individuals can be making some of these decisions? And we've done qualitative work surrounding this, where we identified themes from patients opting for these unproven treatments and identified 6 main themes, mainly negative interactions with their care team, trust in alternative providers and distrust in their conventional providers, perceived efficacy of unproven treatments, dissatisfaction with the conventional cancer treatments. It's something that they find to be compatible with their belief system, predominantly this idea surrounding natural therapies, and the sense of personal control. They wanted autonomy, and they wanted to be in charge of their own care. And then we also wanted to figure out, well, where are they being exposed to this information? Is it just social media? Interestingly, you'll see that the source of this non-traditional treatment information, or unproven treatments or disproven treatments, comes from a lot of different sources. It's just not social media. It's just not online sources. It's close friends and family. It's distant friends. It is some social media and websites. There are support groups. They've said that they've even heard sources for non-traditional treatments from naturopaths and cancer physicians. So again, these are things that we have to be aware of as we create mitigation strategies surrounding these things. And again, in line with prior data, nearly 1 in 3 patients report that these therapies, could cure their cancer. And this was even more significant among individuals who live in our rural and frontier populations, which is an important area of study in my area. So there's some opportunities for addressing cancer misinformation. I know that there's many super bright and intelligent individuals who are likely listening now or sitting in this room who are working on some of these areas surrounding addressing cancer, not just specifically cancer misinformation, but misinformation and health misinformation in general. We have to figure out ways to address it from the sources. We have to figure out ways to address it at the patient level, identify populations at risk, other psychological drivers, ways that we can prevent and inoculate them and improve their discriminatory ability, and then ways that we can address it from the physician side. One of the unique aspects to cancer care and kind of this study of misinformation is that we have this unique relationship between clinicians and patients where we can, in some ways, intervene with those individuals who have been exposed to cancer misinformation and may believe it. And this is where I've spent a lot of my work currently We've done a little bit of prevention work and are starting a pilot study to test these info prescriptions. Basically, after a patient's diagnosed with a cancer, we actually give them reliable places to go to look for information rather than kind of leaving them to their own devices, I guess you could say. So it's being proactive about helping them find accurate sources. Now there's this idea around inoculation, right? Where you give a weakened form of a virus to inoculate somebody from an infectious disease. I'm not 100% sure how that works in the cancer space, but I will tell you, I think there's an opportunity to do some research here. And oftentimes from a kind of a clinical perspective, I will tell patients when I meet them that when you go online, you're likely to encounter things that may sound too good to be true, or you may not have heard of, come talk to me about those if you had, and at least you warn them that that's something that they may be encountering. And this is where I've spent the most of my work currently is kind of in this treatment response area, mostly in the area of patient-centered communication, because despite, I think, our efforts in prevention and inoculation, I feel like at this point it's almost inevitable that our patients are going to be encountering cancer misinformation, and so we have to be able to figure out a way to address it in this setting where at least there's some trust there. Fortunately, at least at this point, it appears that most patients still trust scientists and physicians. So this is a relationship that we need to utilize. This is work that I had previously done with a collaborator at the University of Florida, Karma Byland, where we identified clinician responses to online health information. This study was designed kind of prior to our operationalization of misinformation. So we just kind of talked about low quality information. But there's these 4 models, basically physicians who are unwilling to discuss it, those who are cautious about telling patients to go online, those physicians who are willing to discuss online information, and those physicians who give specific online sources. And this red light approach is actually pretty interesting because I think many physicians think they're doing the right thing for their patients and they're just telling them, don't go online, don't look. But if you tell your patients to don't go online, 95% of cancer patients go online anyway. And so it's not an approach that's going to work. So we often advise in our discussions with physicians not to be telling patients, don't go online, because they're going to go online. We've basically built a communication model to respond to cancer treatment misinformation using a few studies. The first study, we wanted to identify in a qualitative way how clinicians are addressing cancer misinformation. So we did a thematic analysis and identified these 4 main ways. It's ultimately working to understand the misinformation, correcting the misinformation through education, advise about future online searches, and to preserve the clinician-patient relationship. Please be aware, this is not the best way to do this. We've not gotten to that point in the research yet, but this is how physicians are currently trying to address misinformation. So this explains exactly how to approach kind of each of these steps. I'm going to take you to study 2, where we expanded on these themes to get at how and what skills physicians use to explain this model. So we basically identified how physicians communicate with patients to work to understand this misinformation. How are they correcting the misinformation through education? How are they advising about future online searches? And in validating this model, in expanding on the model, we were able to do a vignette experiment evaluating the strategies for correcting misinformation. So there's 3 conditions that we use. The first is to state the information is incorrect and explain why it's incorrect. The second condition is to explain why the information is incorrect. And the third condition is to explain why the information is incorrect and emphasize the importance of a scientific base for quality of information. Now, these conditions are all very similar. We interviewed nearly 300 cancer-naive patients in this experimental vignette where they were asked to imagine as if they had a new cancer diagnosis and encountered information about vitamin C. And then we asked them to measure their belief in whether vitamin C is a cure or not. And then we had them go through the conditions where the doctor responds using a certain approach. And there was these post intervention measures. Again, we asked the post-belief, their satisfaction with the response, and the trust in the oncologist. Because all the conditions were so similar, there was no significant differences in satisfaction or trust in oncologists, and all three of the responses reduced the belief in the misinformation significantly. So we still have a lot of work to do in this space, because I think there's other things that may be better at addressing cancer misinformation. And it could be that instead of just maybe correcting, that we could be adding other things like discrediting. This is a very slick study led by Dr. Bryony Swire-Thompson, looking at discrediting a disinformation source. And I really love this study. Basically, it's an opportunity to look at the correction, but also highlight low expertise, combine both of these approaches together. So there was 3 experiments in the original study, but I'm just going to talk about 2 of them. And the first was a sample of 300 patients looking at prolific, and basically said there's this source that seems credible. It's a PhD from Cal Berkeley, is a lecturer and researcher in integrative oncology. So you can tell from the diploma and the cap there that he is very credible. So you ask in a kind of a pretest way how patients rate the source credibility. And then there's the correcting the disinformation, and you basically can highlight that this person's made incorrect statements in the past. So you can say, you know, Dr. Davis said that fluoride in water can increase your likelihood of cancer. This is false. And then when you do that, or people could have got a low expertise condition where Dr. Davis actually is not qualified to give medical advice. His PhD was in anthropology. And then there's a control condition where they say he's a photographer and likes cooking. And again, you do a scale where you're looking at the disinformation and the belief in that. And then we also looked at post-test source credibility, and also at this complementary and alternative medicine belief inventory, which is shown to increase misinformation in the past, or belief in misinformation. And then this experiment was followed with a second experiment where correcting disinformation and low expertise was combined. These are based on these hypotheses surrounding why trustworthiness is important, source credibility is important, and why individuals who may believe in complementary and alternative medicines may believe more misinformation. And if you look at the results here in experiment 1, you can see that low expertise and correcting disinformation, both when compared to control, decreased the belief in disinformation. When combined, they both were better than either individually, but all 3 were still better than the control. If you look at the pre and post-test credibility, you can see that individuals who, the blue line here, sorry, I cut off the legend. The blue line here is the low credibility. The purple line is the combined. So you can see low credibility is better at reducing credibility as compared to the control there. So, and then this is always kind of an interesting graph. I put this here because belief in disinformation was higher among individuals who believe strongly in complementary and alternative medicines at baseline. And then when you looked at it in the post-intervention space, those individuals who believe strongly, it was much harder to correct. So it basically presents a real challenge for physicians who are encountering individuals who have strong belief in complementary and alternative medicine. So highlighting low expertise was equivalent to or more effective than the other interventions. Source credibility, a low expertise, again, consistently more effective than correcting disinformation and conflicts of interest. And lastly, participants who endorse this complementary and alternative medicine were less likely to reduce their belief in disinformation and credibility ratings, which is challenging. So I just quickly wanted to mention how we can expand on our strategies for addressing cancer misinformation. There's some patient-specific tools. We've done some work on using ChatGPT.
Thank you. So on the topic of trustworthiness and credibility, having an anecdotal experience with a patient or family member who was a cancer patient. I think what I've realized is that actually patients trust other patients, especially other patients who can go on and say, this is how I cured my cancer. And I think as a clinician, there's a certain level of maybe legitimacy from a patient perspective that unless you've had a personal encounter with cancer, you just might never have that legitimacy to a patient. And I'm just like asking, how do you reconcile that in terms of like credibility and trustworthiness?
Yeah, I mean, and it's a real challenge. I think there's systems levels issues with the physician-patient communication model. Some of that is surrounding how limited time we have to even communicate with patients. You'll see research out there where you'll see now physicians have 15 minutes or less to spend with an individual. So it's not just that they may not have the personal experience that provides the legitimacy, but they have basically no opportunity to develop any trust with their patients. So there's a lot of issues with physician patient communication model here that is not necessarily addressable. I do think it's important when people talk about public health policy measures, ways that we can improve the quality of cancer information out there is by engaging individuals in the community in positions of trust. It might be a clergy member in a highly religious population or a pastor. It might be other trusted individuals, but it might be a support group via Facebook. And it might mean in some ways engaging with influencers on social media who, again, have that legitimacy, or at least the patient perceived legitimacy. So we studied ChatGPT to evaluate the cancer myths and misconceptions. Overall, it was pretty good at answering questions correctly. The challenge is that it answers common questions very well. It may not answer uncommon or unique questions very well. And this study was done via version 1 of ChatGPT when it first came out. And now there's a dozen chatbots that can be used. So we've already been surpassed in our ability to make strong statements about the validity of this tool. In terms of other tools, there's this thing called the CRAP score that I basically adapted from a library resource for cancer claims. And what it is it's a way for patients to evaluate whether the information that they're looking at is crap. And each letter stands for something. C is conspiracies or claims too good to be true. R is request for money. A is for anecdotes. And P is looking at publisher. And you can score it. You can see this highly technical and scientific scoring system down there at the bottom, going from, stay vigilant to crappiest crap ever. So this is just a way to help patients be able to be critically minded as they're evaluating their cancer information. Now, there's a lot to be studied, and we have a long ways to go before we can say, hey, this is the best way to approach this, and we're not entirely sure. I use a elicitation interview or calibration of certainty technique when I'm talking with patients who are unsure about conventional cancer treatments, and I will frame it in the context of the unproven cancer treatment that they want to use. So, for example, I may say, how sure are you that rectal ozone will cure your prostate cancer on a scale from 0 to 100%? And this helps quantify their confidence in that belief. And then you can say, how come you're not 100%? They may say, I'm 80. And you may say, well, how come you're not 100? And you can get at kind of have them reflect on any doubts or uncertainties they might have. And you can say, how come you're not at 0%? And you can get at how they articulate the reasons that they do hold that belief. And that's a great way to build trust with patients. In the meantime, I try to empower them, recognize the role of their lived experiences, and acknowledge that, hey, they're going to use the internet, and give them accurate sources, because we have a lot of work that we need to do, and we are kind of in the thick of it currently. So we've got to come up with practical ways to communicate better with patients, and we've got to come up with system level improvement at a kind of health policy level, so we have time to develop relationships with our patients. This is special thanks to lab members, special thanks obviously to multiple collaborators across the world who've been working on this important issue. That's all I have. Thanks.
I have time for 1 or 2 questions. Thank you. And amazing, just amazing. I really, really appreciate all of your work in this space. Um, I'm trying to think how to put this. It, one of the things I've thought about a lot as someone who studies misinformation is there's a certain framing of the issue when you use the word misinformation as compared to, let's say, misbelief, misperception, and so on, or distrust. When we say misinformation, it gives a sense that there's sort of these bits floating around. If they stick to you, you believe the wrong thing, and and then bad things happen downstream. And I wonder, and a lot of this has to do with the clear sort of massive amounts of information. There's very clearly visible misinformation out there. We can see it. It's very easy to find cancer misinformation online. But I wonder if we were looking 30 years ago, or 40 years ago, or 50 years ago, do we think the issue would have been better, worse? I mean, I'm sort of asking you to speculate here, but also then thinking about the framing of this as a misinformation problem as compared to all the people you talk to, by definition, are talking to a doctor, right? They're talking to someone that they're willing to talk to a doctor, even, right? But then the ones who don't do the right thing, somehow they're not trusting enough to take the right course and so on. So like I'm trying. I've often tried to wrestle with where's the focal point of the problem. It's definitely a problem when people don't get the functional treatments. That's very clear. The question is where we put the causal attribution and how much this is, we think of this as in a contemporary moment where we can see all this misinformation, but is it really about our information ecosystem versus something else that has always been there?
Yeah, I mean, these are the questions that I'm trying to answer. It's so challenging to determine the source of any individual. In fact, when we did this study that was interviewed basically 750 cancer patients in the Intermountain West region across several states, and we're asking them about the sources. We were able to kind of get at like what's misinformation, but we didn't ask them directly what misinformation, but basically these unproven treatment recommendations, cures for cancer that aren't actually cures for cancer, myths or misconceptions. And we asked them all of these questions. And when you ask them these questions and where they heard about this stuff, it comes from all of these different sources. So it's almost impossible to say, oh, it's just social media, right? I mean, I think people think of the snake oil sales. I mean, the snake oil salesman existed way before the internet, right? And they were going from town to town. I think the challenge is now we live in a time where instead of the crazy guy at the end of the bar who's spouting off insane things that maybe 3 people may hear, he has a podcast with 3 million listeners daily, right? And that is the challenge that we're faced with. And then you add into that these algorithms, right, that exist where the purveyors of the misinformation have basically incentivization to be able to put out things that are controversial because it gets more engagement. And then you get the silos where the people who are faced with the misinformation are getting more of that misinformation. And it creates this kind of perfect storm. In terms of addressing it, that's kind of what we need everybody's help doing.
Great. Thanks.
Yeah, one.
Oh, did that? Okay, very quick, I promise. Super interesting. Thank you. So I'm curious about kind of the more generalized pattern of how this fits into trust in medicine. So, in a sense, you can think about this as playing whack-a-mole with, sort of just cancer, that these things pop up and there's people who are profiting from it, but then kind of thinking about how that ties into the generalized trust in medicine. And so, so in the time that you've looked at this, you're going through the COVID crisis, so kind of something kind of tangible, have you seen an interaction between kind of generalized trust in medicine and cancer? I'm just sort of wondering how to think about this holistically and to put a specific point, thinking, has the experience of the last few years shown you anything that might be at this larger question? Because you talk about using trusted sources, and probably it's like we're running out of trusted sources. So think about like what can we do to kind of to address that?
Yeah, I mean, I think to get it actually the point that was made in this prior question, yeah, I'm, you know, sometimes there's bias I mean, I'm seeing people and I either bring this up. There's a lot of people who I'm not seeing. I was bringing up to Bryony earlier, we say physicians are still trusted resources. We say scientists remain trusted resources, but that's based on Pew Research of individuals who would fill out a Pew Research study, right? So there's a lot of individuals out there who probably aren't going to respond that way. My sense is that it's gotten a lot worse since COVID. Sitting in a doctor's office, there is a lot of angry individuals who, for whatever reason, are putting that anger towards physicians and in other situations, I'm sure scientists and government organizations. And the thing that I saw during COVID that became very clear to me is that patients are super uncomfortable with uncertainty and that involving information. So as you can see, we're getting new information about COVID, recommendations are changing, and people hated that. And I would try to explain, this is a feature of science. This is what we expect to happen as we gain knowledge. But people did not like changing recommendations. They did not like the uncertainty that came with that. They didn't like to hear that a vaccine wasn't 100% effective. And that same thing happens in cancer, right? Where they don't want to hear that chemotherapy has an 80% effectiveness when they can get vitamin C and they've been told that it has a 100% chance of cure and no side effects, right? When they sit with me and I say, you know, there's a chance that you could have long-term morbidity from my treatments. You may be feeling sick for several months. And so it's a hard sell when you are using facts. And it's tough when you're faced with individuals to get a kind of wade in this fact-free environment that they've created. Does that answer it? Is that?
Yeah, no, I'm just kidding.
It's much worse since COVID. I will say we have some data that's unpublished that says that individuals still think physicians are trusted since COVID amongst that 750 survey population that we did in the Intermountain West. But again, that's regional and specific to people who'd fill out our survey.
Thanks very much.
Yeah, thanks.